Aloha and welcome to General Pharmacology. Let's move to the PowerPoint slides and get started today. Today we're going to talk about diuretics and we're going to talk about agents to treat hyperlipidemia. So first off, we'll start with diuretics. All right, so section 2, I started off with neurotransmission. We went from neurotransmission to autonomic pharmacology, and those are two very important concepts to understand as we move forward. After autonomic pharmacology, our next step was high blood pressure. And sure, some of the drugs that we use to control high blood pressure have to do with the autonomic nervous system, but other medications that we use for high blood pressure have to do with the kidneys. And so here we're going to move towards the cardiovascular direction. We're going to talk about diuretics and their effect on the kidneys, and then today we'll talk about hyperlipidemic agents to treat hyperlipidemia. Then we get to section 3. We're going to start talking about central nervous system pharmacology. So today we're talking about diuretics. And a diuretic agent is any agent that increases the volume of urine. So each diuretic agent acts upon a single anatomic segment of the nephron. Each diuretic agent acts upon a single anatomic segment of the nephron. And the action of each diuretic can be best understood in relationship to its action upon the normal physiology of the nephron. All right, well, that's all fun to talk about. Let's see the cartoons. And so here is a cartoon of a nephron. And we'll go through this. By the way, studying renal physiology in medical school was one of the most fascinating things that I ever encountered. When I was in medical school, I was all into neuroscience. That's why I keep saying neuron when the word is nephron. But it was really studying renal physiology that made me realize that the body has a lot more interesting parts than just the brain. And so if you ever have the opportunity to really study renal physiology in depth, it's very fascinating. All right, so we're going to take this nephron part right here, the glomerulus, and we're going to make cartoons out of this. And so what we see is the glomerulus. That's the actual filter. It's like a colander. When you pour spaghetti into a colander, the water comes through, but there's stuff left inside of the colander, and that colander is this glomerulus. And there's a little artery that comes in, the afferent arteriole. Coming in is afferent, and then there's a little artery that goes out, and that's the efferent arteriole. And so we're going to take the cartoon and turn it a little bit. You can think of the glomerulus like a colander. Here I have it like a coffee filter, but instead of the water just going in and dripping through, the water does come in and out of the filter, but something does filter from it, and that is the filtrate, and we can call that the pre-urine. Oh goody, this is what I was looking for. All right, back when I had time to animate these sorts of things, each glomerulus is a capillary bed, but there's little holes in the capillaries where the fluid can fall through. If you ever watch red blood cells go through the capillary, they stack up like donuts. And so here my little red blood cells from the blood are stacking like donuts as they go through the glomerulus in the twisting pattern, not straight. And there's little holes that allow the filtrate to come through. All right, so the glomerulus will be like a colander, allowing the blood to having the the pre-urine come from the glomerulus, and it's collected into Bowman's capsule and then collected in the tubules. All right, I think we got through that okay. All right, so again, once the blood is filtered, the fluid that comes from the glomerulus into Bowman's capsule and comes into the tubules is called the filtrate. And so in our picture, we see the tubules are all convoluted and loopy, and we're just describing the filtrate as just one single compartment of fluid right here. All right, well, when the blood passes through the glomerulus and the filtrate comes through and collected in Bowman's capsule and comes into the tubules, well, there's all sorts of nutrients in that filtrate that your body has to take back. If your body doesn't take that back, bad things will happen. You will lose all of this out of your urine very quickly if we don't reabsorb these nutrients. And so I want you to think about the words reabsorption when we're talking about renal physiology. And so again, the filtrate, this over here, contains all sorts of nutrients: water, sodium, potassium, a hydrogen ion, chloride, bicarbonate ion, magnesium, and calcium. All of these things have to be brought back into the blood. I'll tell you right now, I listed water first, but in order of what happens, water is actually last. Okay, so think about water being last. I put it top of the list because it's important. But as far as where in the tubule, think last. All right. And again, the filtrate has all these nutrients that we have to reabsorb back into the blood. And we'll do that with these little pumps. So notice my filtrate, as I pump water out of the filtrate and pump the water back into the blood, my filtrate decreases in volume and becomes more concentrated. Let's watch the rerun of that. All right, so there's my filtrate, and it probably has no yellow color whatsoever. And as I pump the water out of it, the urine volume, the filtrate volume decreases. And so this is one of the essential things going on with the kidneys, is to pump water out of the filtrate. And notice the filtrate becomes yellower and more concentrated as we pump the water out of it. Well, think about this. The definition of a diuretic is to increase urine volume, not decrease it. And so think about it now. If we do something to block the water coming out of the filtrate, then we increase filtrate volume. Well, not only does water need to be reabsorbed, salt needs to be reabsorbed as well, and wherever the salt goes, the water goes too. And so here we're reabsorbing sodium back into the blood, and by reabsorbing sodium back into the blood, the filtrate is decreasing in volume, because wherever the sodium goes, the water goes too. Please be on the slide. There it is. And so when we pump sodium out of the filtrate, water will follow the sodium. And so because we're pumping water out of the filtrate by pumping sodium out of the filtrate is decreasing in volume and increasing in concentration. Well, if we block this pump, we will prevent pumping water back into the blood, therefore increasing filtrate volume. All right, well, something else we do is we pump calcium and magnesium out of the filtrate. There's my magnesium, all right? And so these are normal body processes that we use to reabsorb our essential nutrients back from the filtrate. But you can see if we block the pumps, then we don't allow that magnesium to come back in the blood. And so something we'll talk about later is how diuretics not only increase filtrate volume by blocking these pumps, but we can lose magnesium and calcium by blocking these pumps. Well, your kidneys also excrete. All right, before we're talking about reabsorption, pulling the nutrients we need back into our blood. However, the kidneys also excrete toxins from the blood to the filtrate. And so when whatever this toxin is right there, we'll say it's uric acid. And the uric acid didn't end up in the filtrate, up in the glomerulus when it was collected by Bowman's capsule. There was no uric acid in the filtrate. The uric acid has to be pumped in the filtrate through active facilitated transport. All right, well, if you look at a complicated pharmacology book, they will draw the glomerulus or they'll draw the nephron like this. And so here's the glomerulus. And then there's this zigzag tube that's close to the glomerulus. We'll call that the proximal convoluted tubule, proximal close convoluted zigzag, all right? So here's our close zigzag tube. And then there's this big loop. We'll talk about loop diuretics and why this loops into the center of the kidney before coming out is really one of the most incredibly fascinating things about perfusion and osmosis. I mean, it is really incredible to realize what happens in the loop of Henle. But all I need you guys to know are there are loop diuretics, and they're going to block these little pumps that we're talking about. All right, so after this incredibly miraculous loop, then there's a faraway zigzag tube. So that's the distal convoluted tubule. And then it goes into the collecting tubule, the collecting duct, and eventually into the ureters. And notice here, this is where water is pumped back into the body, reabsorbed because of antidiuretic hormone, down here in the collecting tubules. So let's start with thiazide diuretics. We talked about that during high blood pressure. Thiazide diuretics inhibit sodium chloride reabsorption at the distal convoluted tubule. And so when we are talking about these pumps, remember pumping sodium into the blood carries the water with it, decreasing urine volume. So if we block the pump that brings sodium back into the blood, we're leaving sodium and therefore water in the filtrate and expanding urine volume, and that's our definition of a diuretic. And so by blocking sodium chloride reabsorption in the distal convoluted tubule, we increase urine volume. But remember, we also use these pumps to pump out stuff we don't want, like uric acid. And so by blocking the sodium pumps that reabsorb sodium, we increase urine volume, but we also block the pumps that are excreting uric acid. And so thiazide diuretics will cause uric acid levels to go up. And so if we have somebody with gout, gouty arthritis that's due to crystallization of increased uric acid levels in the blood, then there is a good possibility that thiazide diuretics can make that gouty arthritis worse by increasing uric acid levels. So we talked about thiazide diuretics being indicated in high blood pressure. That's where we're going to see thiazide diuretics used most of the time. But we can use it in congestive heart failure. We can use it in kidney stones, nephrokidney lithiasis stones due to high calciuria, calcium urine. We might see thiazide diuretics used in nephrolithiasis due to hypercalciuria, and that's kind of rare. Even more rare than that is diabetes insipidus. Thiazide diuretics in diabetes insipidus doesn't make much sense, and we'll come back and talk about this. And so if you know that diabetes insipidus doesn't seem like something we would treat with thiazide diuretics, we will come back to that. And so the bottom three, I'm not too worried about. It's the top one I want you to know about thiazide diuretics. This diuretic is indicated and used mostly for high blood pressure, hypertension. But there are toxicities involved with blocking pumps that are part of our natural day-to-day balance, our homeostasis. And so something we have to keep in mind when we're using thiazide diuretics is they can cause hypokalemia, low potassium. They can cause hyponatremia, low sodium. And again, they can lead to hyperuricemia, high uric acid levels. And so most importantly on this list is hypokalemia with thiazides. And this as well, I guess this should be at the top of the list as well. We'll talk about sulfonamides when we get to antibiotics, and when you talk to clinicians and they talk about sulfonamides, they think antibiotics, sulfa antibiotics. However, there are many drugs that are based on those sulfa antibiotics that are called sulfonamides, and thiazide is one of them. And so if people are allergic to sulfa drugs, there's a good possibility that they're allergic to thiazide diuretics as well. And so allergic reaction is something that we are on the lookout for and asking about when we give thiazides because a lot of people don't know that thiazides are sulfonamides. And then photosensitivity, many medications, as we get out, if we take the medication, we get out in the sun, can cause increased ability to sunburn, and then rashes as well. These red rashes that result from being out in the sun. This is much more common in light skin than dark skin. However, thiazides are one of those drugs that can cause photosensitivity. Now, there's plenty of people in Hawaii taking thiazides, getting out in the sun, not having photosensitivity, but this is something that we need to think about with medications, because if your patient comes to you and says they're allergic to sulfa drugs or they have a problem with photosensitivity when they take this medication, we need to listen carefully and be aware that thiazide diuretics have the potential to do that, because a lot of people are on thiazides. And many times when a patient has complaints like this, they get written off by the clinician like the patient has no idea what they're talking about, when in reality it's the clinician that is not well versed in pharmacology, hence pumping all this stuff on TV all the time. In your clinical discussion section, there are many drugs that are used in combination with hydrochlorothiazide to treat high blood pressure. And so again, I want you guys to take a look at those and just be aware that we can add a little bit of hydrochlorothiazide to a little bit of any other antihypertensive and get multiplied results, better results than using more of either of the drugs alone. The star of our show for diuretics is the loop diuretics, furosemide, Lasix. If you work in a hospital, if you work in a surgical intensive care unit, or if you work in any intensive care unit, a cardiac intensive care unit, this is going to be the most common diuretic that you use. This is commonly used in the hospital for all sorts of volume control. There's all sorts of people who take Lasix as well in its oral form. Loop diuretic, furosemide, Lasix. How did he get that trade name? Last 6 hours. That's always what they told us Lasix came from. And so that was a good thing to remember. All right, instead of preventing salt reabsorption in the distal convoluted tubule like thiazides, loop diuretics inhibit sodium chloride reabsorption in the loop. And that's what I know. The thick ascending loop of Henle? No, in the loop. All right, that's what I want you to know. Sodium chloride blocks sodium chloride reabsorption in the loop. That's why they're called loop diuretics. And so here's our thin descending limb, the thin ascending limb, and now we're at the thick ascending limb. I don't need you to know any of that. What I do want you to know is, because Lasix blocks sodium reabsorption, it also blocks potassium reabsorption, it blocks magnesium reabsorption, it blocks calcium reabsorption, and it interferes with the excretion of uric acid. And so these are things that you need to know when you are taking care of your patients that are requiring Lasix. They work great. They're very efficacious. That's why we use them. They work quickly. They have a very short duration of action. Getting the kidneys moving along is a great way to use loop diuretics as well. And they work really quickly. If you take someone who takes a Lasix tablet by mouth, we can expect it to start working within the hour. And the peak effect is within 1 or 2 hours. And they tell us the duration of the effect is 6 to 8 hours, lasts 6 hours. If we give it IV, it works immediately. So what do we use this for? To reduce left ventricular filling pressure and congestive heart failure and pulmonary congestion. Decreasing preload and afterload are what they'll say in the books. And when we come back next time, we'll talk about what that means, and then this will make perfect sense to you. But something we're going to do with loop diuretics is to treat congestive heart failure and pulmonary congestion. And this is stuff that we're going to talk about in the next lecture. Acute pulmonary edema, acute renal failure. We talked about jump-starting the kidneys not 2 slides ago. And when somebody's having acute renal failure, that means they're having it right now. That's different than chronic renal failure. Chronic renal failure is not reversible in the short term at least, but acute renal failure we can do something about. We want to do something about. If we don't take care of acute renal failure, then we will end up with chronic renal failure. And so sometimes people are in acute renal failure for all sorts of reasons. Maybe they've had a hypovolemic episode and now their kidneys are doing everything they can to retain fluid, and now we need to get them working again. We give them some Lasix, and this is going to increase blood flow and increase potassium excretion as well. This loop diuretics prevent the reabsorption of calcium and magnesium. Remember, we're pumping this stuff back in to the body to reabsorb the calcium and magnesium that we need from the filtrate. And so if we're blocking those pumps, we're going to end up pushing calcium and magnesium into the urine. And so loop diuretics can cause hypocalcemia and hypomagnesemia. And so if we see that, we can use calcium supplements and magnesium supplements. The most important thing I want you to know about loop diuretics is the hypokalemia, low potassium, and then hyperuricemia. Loop diuretics are especially problematic in people who have problems with gout. Keep in mind, a lot of your older patients, they need calcium. They need to keep their calcium levels above low, and so we have a problem with hypocalcemia and hypomagnesemia in certain people who use loop diuretics. And then any drug that causes anything to happen can cause too much of that to happen, and so we use loop diuretics to lower volume. If we use too much loop diuretic, then we end up with losing too much volume, and low volemia is just low blood volume due to excessive use of loop diuretics. Again, loop diuretics are sulfonamides as well, and so they're at risk for allergic reaction. Especially with people who are allergic to sulfas and sulfonamides. Loop diuretics. You need to know everything you can know about loop diuretics, and so go to the Daily Med site or go to drugs.com on the professional side and find the package insert for Lasix and read it carefully. And take a look at the indications and the toxicities. All right, well, thiazides cause us to lose potassium. We don't see that as much as we see Lasix really losing potassium. And so Lasix we associate with losing potassium. And so many times you're going to see people who take Lasix getting a potassium supplement. Later on we'll talk about digoxin, which is used for atrial fibrillation. And it's also very helpful in congestive heart failure. And we're going to use Lasix in congestive heart failure. And so when Lasix is added with digoxin, it becomes a very toxic combination because digoxin is especially toxic in hypokalemia. And so you'll see people who take Lasix and digoxin. We're going to follow their potassium very carefully. We're going to make sure that they get potassium supplements, because Lasix and digoxin can be a toxic combination if we don't follow the potassium very carefully. Which gets us to this, potassium-sparing diuretics. So if somebody has a problem with losing way too much potassium with Lasix, we can put them on a potassium-sparing diuretic instead. Spironolactone, aldactone, is our potassium-sparing diuretic. And so again, take a look at the package insert for this drug, look at the contraindications and the warnings. All right, it's an aldosterone receptor blocker at the late distal tubule and cortical collecting system. At the end of the tubules, you'll see aldosterone will cause us to reabsorb salt, and so if we block that, then we will lose salt into the filtrate and increase urine volume. But it also causes us to retain potassium. Aldosterone pushes potassium out and keeps sodium in. And so if we block that pump, we end up with the opposite. We lose sodium and we retain potassium. So severe hyperkalemia is one of our toxicities with potassium-sparing diuretics. And so if we choose to use potassium-sparing diuretics, then we need to be on the lookout for having the exact opposite problem, hyperkalemia. So remember, Lasix, hypokalemia, potassium-sparing diuretics, hyperkalemia. Gynecomastia is breast growth in men. When we get to endocrinology, we'll talk about the things that go on with the adrenal cortex. The adrenal cortex makes hydrocortisone, a glucocorticoid. It makes cortisone that your body needs to manage stress and other things going on in the body. And then your adrenal cortex also makes this aldosterone. Your adrenal cortex also makes androgens like testosterone and estrogen and progesterone, how much levels depending on whether you are male or female. And so gynecomastia is breast growth in men. And this is because, again, the adrenal cortex is involved in more than just salt and glucose regulation and stress regulation. It's also involved in androgens, the development of the adult features in a human. And gynecomastia is one of the things that we'll see because potassium-sparing diuretics interfere with not only aldosterone, but the other receptors that sense what they're supposed to sense as far as androgens. And so keep this in mind because there's a lot of men on spironolactone that are unaware of this right here. Metabolic acidosis, hyperchloremic, high chloride levels with metabolic acidosis is something that we'll see with excessive use of spironolactone. And that's fine. What I really want you to know is severe hyperkalemia, and don't forget about the men on spironolactone if they're asking why they're having changes in their breast tissue. If you read the package insert for potassium-sparing diuretics, they will say use with extreme caution when using in combination with ACE inhibitors because the combination of ACE inhibitors and potassium-sparing diuretics are notorious for causing severe hyperkalemia. I've met plenty of people who can take both. I met a woman, the last time I met a person on potassium-sparing diuretics and ACE inhibitors, she had a real problem with Lasix. She'd take Lasix, she'd lose her potassium, and she was also on digoxin, and so she switched over to a potassium-sparing diuretic, and then everybody in congestive heart failure is supposed to be on an ACE inhibitor. And so she did just fine, and we checked her potassium on a regular basis, and she did okay. Now keep in mind that people change, people get older, and sometimes they get ill or overexert and their volumes change. And so just because she's been fine with ACE inhibitors and potassium-sparing diuretics for all these years, we have to continuously monitor because things can change and she can become hyperchloremic very quickly. Somewhere in the late 90s, early 2000, the Center for Medicare and Medicaid Services thought it'd be a great idea to switch everybody to potassium-sparing diuretics because the problem with Lasix is we are doing all these lab tests to check for potassium, and they thought it would be more cost-effective that all of our congestive heart failure patients be switched over to spironolactone. Well, they also require, Center for Medicare and Medicaid Services also require everybody with congestive heart failure to be on ACE inhibitors. And so when they came down and said, we need to switch people from Lasix to potassium-sparing diuretics, I'm like, well, all these people are already on ACE inhibitors. And they thought they were going to save money by doing less potassium checks, and that was not the case at all. And it wasn't too many months later they turned around and said, maybe this isn't such a great idea. So be very careful using potassium-sparing diuretics in people who are using ACE inhibitors as well. And we'll see that a lot with congestive heart failure, which is what we're going to talk about in our next class. All right. We talked about thiazides. Those are used in high blood pressure. We talked about Lasix, and we talked about spironolactone. And they're mostly used in congestive heart failure. Lasix being the one that causes hypokalemia, spironolactone being the one that causes hyperkalemia. And so the major diuretics in cardiovascular medicine are thiazide, Lasix, and spironolactone. You need to really know the difference between those three, whether you are going to be a physician or a pharmacy technician. You really need to know the difference between those three. So our cardiovascular diuretics are going to be hydrochlorothiazide, Lasix, and spironolactone. I really want you guys to have a good handle on that. Well, while we're on the subject of diuretics, we're going to talk about some others that are really not used much in cardiovascular medicine. Osmotic diuretics, they're things that end up in the filtrate and then pull water out of the body and put it into the filtrate, increasing urine volume. That's why they say non-reabsorbable. These salts will end up in the filtrate, and they'll be like sponges. They'll be sponging up a lot of free water out of the body, and your body can't reabsorb those. The main place we're going to see those will be used in an ICU situation to control, in this case, control intracranial pressure. We won't get into that today. One thing to understand about osmotic diuretics is when we first put them into the blood through the IV, well, the first thing they're going to do is expand the vascular space. And then they end up in the filtrate, and eventually they will collect free water and increase your urine volume. But at first, they're going to increase vascular volume. So intravascular volume expansion, which happens immediately after it's placed in IV, can make heart failure and produce pulmonary edema. And so if you use a lot of osmotic diuretics in an ICU setting, that's one of the first things you'll see is this intravascular volume expansion. And then it ends up in the filtrate, and then we can see urine volume expansion. However, because we're pulling free water out of the system, the salt levels seem to go up. If you have a saltwater aquarium and you let that, or if you just have a glass of salt water and you measure the level of salt in the salt water, and then you let the water evaporate off, you come back and check the sodium level again, the sodium level's gone way up. It's not because we've added a bunch of sodium to the system, it's because we've taken free water away from the system. And so that's something that we want to think about when we see hypernatremia, high sodium levels. Well, is that because we have a high body excess of sodium? No. What has happened is we've pulled away free water, and when we pull away free water from the salt water, the water gets saltier, and that's not because we've added salt, that's because we pulled away free, fresh water. And so that's where this comes from. So keep in mind that word hypernatremia, rarely does that mean excessive salt levels in the body. Usually what hypernatremia means is a loss of free water, and so we'll see that with osmotic diuretics. All right, we talked about carbonic anhydrase inhibitors when we were talking about glaucoma. And so somebody with glaucoma, they'll use carbonic anhydrase inhibitors to prevent fluid production in their eye. Somebody with benign intracranial hypertension, pseudotumor cerebri, they'll use carbonic anhydrase inhibitors to prevent fluid production in the choroid plexus in the ventricles to prevent cerebrospinal fluid production. And so those are the predominant ways that carbonic anhydrase inhibitors are used. However, they're originally described as diuretics because in that proximal tubule, there's an enzyme called carbonic anhydrase, and it reabsorbs the sodium bicarbonate that is in the filtrate. And so if we block that, then we end up with bicarbonate, our base, our buffering base in the body, and it produces an alkaline urine. And so again, the acetazolamide is our typical carbonic anhydrase inhibitor. We used it to treat glaucoma. We'll use it in pseudotumor cerebri, otherwise known as idiopathic intracranial hypertension, to decrease fluid production in the brain. But again, it can cause hyperchloremic metabolic acidosis. We're preventing the reabsorption of our base, our buffering system. So what we're left with is an excess of hydrogen ions, an excess of acid. And so it makes sense that carbonic anhydrase inhibitors lead to metabolic acidosis. Hypokalemia, again, is another problem with carbonic anhydrase inhibitors when they're used as diuretics, but we don't see them used much as diuretics much anymore. We can use them for certain types of renal stones. That being said, about diuretics, in your clinical discussion section is more information about diuretics and the different types of diuretics in each class. I want you guys to take a look at that and go through the package inserts for those medications and make sure that you have a good handle on what is in the syllabus about researching the medications, their indication, the indication of the drug, its dynamics, its kinetics, and then warnings, what to do in overdose, and things like that. Because you have to do that on your own in this business all the time. If you're going to be in the professional healthcare business, you're going to be looking this stuff up every day. So quit thinking of it as a chore. Think of it as an opportunity to improve the health of your community, because that's what we're trying to do here. Let's talk about hyperlipidemia and atherosclerosis. Remember, we talked about high blood pressure causing arteriosclerosis, which is thickening of the outer wall, and then atherosclerosis, which is this gunky collection in the artery. So there's a slice through my normal artery, and here I have atherosclerosis, and this is a big problem for all sorts of reasons. 23% of people who live in an industrialized country have coronary artery disease, and 42% of all deaths in an industrialized country are due to coronary artery disease. Being a county coroner, I can tell you that they play with these numbers, whether it's 40 or 45 or 50. I don't need you to know that, and so you can just scratch that out and just say half, and you can scratch that out and say a quarter. Matter of fact, I'm going to do that now so I don't have to do that next time. 1/4 of Americans. According to me, 1/2. Just draw it the way I told you here. Yeah, we'll fix that later. I hate it when it does that. Mortality is when something causes death, and morbidity when it is something that is when it causes injury. And so mortality of coronary artery disease is 500,000 each year. Morbidity would be the other one, 1 million from myocardial infarction. And so many people die of myocardial infarction or go to the hospital with myocardial infarction. And you don't see these people when you're hanging out on a college campus, and so your perspective of health is a little bit different when you come to an emergency room and see all the people being wheeled in the door having myocardial infarctions and angina as well. And so coronary artery disease is something that's decreasing our average life expectancy by 10 years. I'll tell you right now, if we can get rid of everything, you would still have to die of something else. And so there is a limit to what we can do by eliminating all these things. If we completely eliminate coronary artery disease, what we really see is people dying of something else. And so we look at those numbers carefully. But what I do want you to see is, and this is in the United States, myocardial infarction affects 1.5 million people annually, and 500,000 of those each year are fatal. And these interesting numbers to keep in mind. Angina, which is chest pain due to coronary artery disease, 5.6 million people suffer from that each year. I think that's incidence. 5.6 million new cases of angina each year. Incidence is the first time we see it. All right, so to understand drugs to treat hyperlipidemia, we got to talk a little bit about lipoproteins. We'll start with the chylomicrons. When we eat, they transport fats from the gastrointestinal tract to the liver. We don't talk about those too much. But we will talk about LDL, bad cholesterol, low-density lipoproteins. And it's considered bad cholesterol because they're taking cholesterol and fats from the liver to the arteries to the body. And that's where it gets the word bad cholesterol. And I was in high school when they started thinking all this out, and I remember my biology teacher telling us how silly doctors were because they were labeling bad cholesterol and good cholesterol, and it's just the same cholesterol. And so she told us that those doctors had no idea what they were talking about. But we're not the ones that actually come up with these words, and so I'm going to tell you where these words come from. Low-density lipoproteins are carrying fats from the liver to the body. And so the LDL number, the low-density lipoprotein, is what we don't want. And that's where that bad cholesterol word comes from. And it's these low-density lipoproteins. We call them bad because the lower the low-density proteins are, the better. And so we want our low-density lipoproteins to be as low as possible. Okay? Our high-density lipoproteins are taking fats away from the body to the liver to be eliminated. That's what we want. That's a good thing to happen to the cholesterol. Take it off our arteries and send it away. That's a good process. And so we want our high-density lipoproteins to be as high as possible. All right, so we want our LDLs to be low and our HDLs to be high, and then most of us that's reversed. Our LDLs are too low, our LDLs are too high, our HDLs are too low. Right. So try not to get tripped up by this good versus bad cholesterol if you're teaching biology to high school students. All right, well, how do we figure out if somebody even has hyperlipidemia? Well, we do something called a lipid panel, which is a lab test. It's a lab draw. It'd be nice if you need to be fasting for 8 to 12 hours, depending on who's drawing your blood, before you take this test. If you drink alcohol within 24 hours of your test, your triglycerides can be excessively high. Now, I had a next-door neighbor, the landlord, who walked onto the property on a daily basis, and he was getting his triglycerides checked, so he came out and wanted medical advice from me. And I told him to be sure and avoid alcohol before getting this test because we don't want the triglycerides to be elevated. And he came in chastising me because he decided that he would drink as much as possible before his test, and his triglycerides were just fine, and he wanted to tell me that. And so first of all, don't drink alcohol within 24 hours of your test if you want it to be accurate. And if that doesn't apply to you, that doesn't mean you should drink more alcohol because you're getting the lab test, because that really just doesn't make any sense whatsoever. So avoid alcohol within 24 hours of these tests. And again, there's all sorts of panels that can come up, but we'll take triglycerides are down here. That's one form of lipid. And then cholesterol is a different form of lipid. And they'll divide that up into total LDL and HDL. Primary hyperlipidemia is inherited. It can be high cholesterol. Maybe we'll call that hypercholesterolemia. Maybe we'll call it hypertriglyceridemia. We can call either one hyperlipidemia. You can have one or the other and have hyperlipidemia. You can have both and have hyperlipidemia. Usually we see one or the other, but sometimes we see both hypercholesterolemia and hypertriglyceridemia. But again, these are familial. That means they run in the family. There are secondary reasons for hyperlipidemia, and there's a big list. Alcohol is certainly one of them. Chronic alcohol use can result in hyperlipidemia. The most important one up here is diabetes mellitus. Diabetes mellitus is the disorder of glucose regulation. And one of the first signs of diabetes mellitus can be secondary hyperlipidemia. I've seen that several times. I've seen before when I was in regular practice as a hospitalist, I saw all sorts of people who are diabetics. They had diabetes mellitus, and its first manifestation before anything else was hyperlipidemia. I came to Hawaii and saw somebody with hyperlipidemia, and I said, you know, I'm wondering if we need to start treating you like an early diabetic, because sometimes the first sign of diabetes mellitus is this hyperlipidemia right here. And so after seeing him with hyperlipidemia, high triglyceride levels, I said his diagnosis was diabetes mellitus. I wanted him to see the dietitian and get counseling on how to take care of diabetes mellitus. And I can assure you, the insurance company came down on me. They sent some kind of medical expert fresh out of nursing school to come tell me that they had no sign of diabetes mellitus, and they wanted to have a frank discussion with me about my practice of medicine. And then about a year later, I get an email, or I get a consult note from a endocrinologist who, after about a year, the patient indeed did have diabetes mellitus, and it did manifest itself in a high hemoglobin A1C, and so they sent me a letter telling me that yes, indeed, he did have diabetes mellitus, and that's why all those hypertriglyceride drugs that he was using didn't work, because we still have to control this. Even if we don't see the clinical manifestations of this, if they have secondary hyperlipidemia due to diabetes mellitus, then this is what we want to treat right there, the diabetes itself. And obviously that's not stuff she must have gone to school before I started teaching this. All right, there are old recommendations for the use of statins in the treatment of coronary artery disease. And we call them old, and the fun thing about this business is when something's old, we just think we're going to throw it out and it's going to go away. But the reality is, all these years later, we still see this nomenclature, we'll still see this philosophy being used in the treatment of hyperlipidemia and hypercholesterolemia, hypertriglyceridemia. So we are going to go through the old version first, then we'll go through a newer version, and then realize that it gets really complicated quickly. So here are some risk factors that we're going to think about when we're looking at somebody who has hyperlipidemia, hypercholesterolemia, hypertriglyceridemia. All right, do they have evidence of coronary artery disease? What's evidence of coronary artery disease? All right, well, they have angina, they go to the cath lab, and they have coronary artery disease. All right, well, we're going to be real aggressive about that. What if their HDL is less than 40? That's a risk factor we want to think about. We want our HDLs to be higher than 40, and so if their HDLs are less than 40, then they are at risk of atherosclerosis and premature coronary artery disease. If they have a family history of premature coronary artery disease, then they are at very high risk for coronary artery disease. Smoking, high blood pressure, diabetes mellitus, all of these can result in atherosclerosis and a coronary artery disease. And how many people do you know who smoke and have high blood pressure and are diabetic and have a family history of coronary artery disease and HDL is less than 40? And all these things, they don't add together, they multiply with each other. And so we have to be very aggressive about determining evidence of coronary artery disease, asking histories if they have a history of premature coronary artery disease, looking at their HDLs and their LDLs. Do they smoke? Please quit smoking. Let's work on that today. High blood pressure, that's really easy to control with diet and exercise and a little bit of medication if that's not going to be complete. And then diabetes. We got to control diabetes mellitus because it's notorious for causing coronary artery disease, and all these things multiply together. So that's why the more risk factors that a person has, the more aggressive we're going to be about treating their hypercholesterolemia, their hyperlipidemia, hypertriglyceridemia. Our goal in all those situations is to lower the low-density lipoproteins. All right, so let's say they have no coronary artery disease and they have less than 2 of the risk factors listed right here. All right, so that means no evidence of coronary artery disease and then less than 2 of those. The old guidelines were, well, we'll keep their LDLs less than 160. Now, there was a problem with just using an absolute number, and so we see that in the new guidelines. But the old guidelines, oh, we want it to be less than 160, and the reason these are still in the slides is I see this when I'm reading stuff in all right, so if they have no coronary artery disease but 2 or more risk factors, we can keep their LDL less than 130. Managing somebody's LDLs is not this simple, but at least these are the recommendations. All right, and the star of all of that is this right here. If they have coronary artery disease, we want their LDLs to be less than 100. And you'll still, I heard somebody the other day, like, oh, well, you know, this happened, and so they're telling me to keep my LDLs less than 100. Why? Because this is the easiest way to communicate with people. And so this is why we still see these goals to lower LDL in this manner. Oh, well, you need to keep it less than 160. Well, you need to keep it less than 130. You have to keep yours less than 100. That's really simple way to communicate. But sometimes simple communication is not the strategy of certain people, and so now we have new LDL guidelines, which have been around for, I guess, about 10 years. And I think there's newer ones that are more complicated than this. And so we're going to divide our patients into 4 major statin groups. All right, so these are called statins. The type of medications that we use to lower cholesterol are called statins. HMG-CoA reductase inhibitors are called statins because their generic term ends in statin, and so you'll hear that statin word used. And so there's 4 groups of people who we think are going to use these medications. All right, well, individuals with clinical atherosclerotic cardiovascular disease. If you recall from our last list, people with coronary artery disease, we want them to keep their LDL less than 100. With the new guidelines, it's a little bit different. And so, again, we're picking out 4 groups here. Individuals with clinical atherosclerotic cardiovascular disease, we want to be very aggressive with them. We're also going to be aggressive with individuals with LDLs of greater than 190, like those people with familial hypercholesterolemia. Individuals with diabetes who are between 40 and 75 years old with LDL cholesterols between 70 and 189. Even if they have no evidence of atherosclerotic vascular disease, we're going to be really aggressive with these people. Why? Why 40? Because it takes a long time to develop atherosclerosis due to hyperlipidemia. Why do we cut it off at 75? Because their life expectancy isn't really expected to exceed how much time it takes for that atherosclerosis to develop. And as people age, they actually need more lipids and cholesterol as well. And so that's why they created this age range. All right, and then the last group we'll talk about are individuals without evidence of cardiovascular disease, but they have LDL cholesterol levels of 70 to 189 and a 10-year risk of atherosclerotic cardiovascular disease. There should be a risk profile on my slides. We'll see if we can find that. All right, so in individuals with atherosclerotic disease, instead of saying, oh, we want to keep your LDLs less than 100, something we realize is there's only certain statins that increase life expectancy in these populations. And so something that we noticed is that somebody would have atherosclerotic coronary artery disease, and we'd give them a certain statin and we'd lower their cholesterol, but we realized that their life expectancy did not improve. And so these high intensity statins, that philosophy came from there's a group of statins that seem to extend life expectancy when they're being used to treat atherosclerotic disease. And so here we want to achieve a 50% reduction in LDL from what they had when they were diagnosed with the coronary artery disease. And so if their LDLs were 200, then we want the reduction of that, we want to bring their LDLs down to 100. But if at the time of diagnosis their LDL was 160, we're going to want to keep their LDLs even lower than 100. We'll want to keep them down at 80. And that's not easy to do. But these are the newer guidelines than the previous ones I showed you. If they can't tolerate high intensity statins, we'll use a moderate intensity statin instead. Well, people with LDL cholesterols greater than 190, high intensity statin should be used with the goal of cutting that in half. And so here is somebody with high LDLs, and we're going to use a statin to just cut that in half. And so higher than 190, that's definitely, we're keeping their LDLs less than 100, even if they have no evidence of coronary artery disease. We can use a moderate intensity statin for this group. That lowers cholesterol from 30 to half. All right. So again, up to half, not more than half. All right. But about 30% reduction is what we look for in this group. Did we get everybody? Good. 1, 2, 3, 4. All right. Now they're the same. Anyway, this is what you really want to know about the treatment of hypercholesterolemia. I won't ask you questions about the new guidelines, by the way. All right, this is the important part we want to teach you in a pharmacology class about lowering cholesterol, lowering triglycerides, managing diabetes mellitus for that matter. This is how we manage atherosclerotic disease. This is how we prevent heart attack. This is how we prevent stroke. This is how we prevent all sorts of problems with atherosclerotic disease, this right here. Top of the list should be increased physical activity because exercise gives our cells this protective chemistry to them that lazy cells would not have. Diet and exercise, that's very important. Losing weight. If we're gaining weight, then we're probably not doing enough of this up here. And so we want to be on the proper diet. That's not just any diet, the proper diet. And then we want to reduce weight. Alcohol interferes with the metabolism of how we manage energy. And it's very difficult to lose weight and drink alcohol excessively. Smoking is known to cause atherosclerotic disease, increased risk of heart attack. So if we can quit drinking, quit smoking, at least do a lot less. I don't need you to quit unless you're really good at that. You can do that, but less is great. Right? Less is definitely a first step. But controlling high blood pressure, controlling diabetes mellitus is essential to controlling coronary artery disease. So that, again, it's so important to tell our patients that we really have to control their high blood pressure. We'll talk about diabetes mellitus when we get into endocrinology. All right, so what are some of the treatments for hypercholesterolemia? Well, niacin, nicotinic acid, is a natural occurring vitamin, and we can use that to lower cholesterol. I think some of the newer things we're reading is that they don't think this is a very good recommendation. However, I'm still old, and I think this is a great recommendation. There are certain reasons to avoid nicotinic acid. Active chronic liver disease, peptic ulcer disease, diabetes mellitus, and gout can be problematic with, those people can have problems with nicotinic acid. The one thing I want you to know about nicotinic acid is this flushing sensation. They'll take the nicotinic acid and they'll feel red and hot, and their faces will be red, and they'll feel very anxious. And that's something called flushing. And so that's why we want to give the nicotinic acid a very sustained release. It takes a few days for them to get used to it. Yeah, they can have all the rest of this stuff too. Flushing is what I want you to know. You can take it with food. Don't take it with hot liquids. Don't take it with a bunch of caffeine. And taking a little bit of aspirin beforehand can reduce flushing. And so again, a lot of people who have high cholesterol and coronary artery disease, will put them on an aspirin to prevent blood clot formation. And so it makes sense that if they're taking an aspirin every day, we'll take that before the nicotinic acid, and that can help reduce flushing. But we're not going to want to use them if they're going to take statins or fibrates. The whole point of taking nicotinic acid is to avoid statins and fibrates. One of the researchers who helped start all the statin business was a big fan of nicotinic acid, and he made it very clear to us that we want to try that before this. And then the last thing I read, so, oh, well, we don't think nicotinic acid works as well as it should. And I'll let others make those decisions. Somebody's taking nicotinic acid, we're going to monitor them the same way we're going to monitor somebody with a statin. So we're going to get liver function tests. They have all sorts of names. ALT and AST are one of them. Fasting blood sugar, test for diabetes, uric acid levels. We're going to want to know these things about we're going to want to know those levels on anyone who's taking nicotinic acid. Bile acid sequestrants. This is an interesting way to lower cholesterol levels. You have this thing called enterohepatic cycling. Your liver will dump bile full of cholesterol into your small bowel, and your small bowel will reabsorb all that cholesterol back into the portal system, which goes to the liver and dumps all that bile back into the small bowel, which pumps it back up and into the liver, which then dumps it back into the small bowel. And so that's called enterohepatic cycling, where the liver is putting the cholesterol into the small bowel while the small bowel is just reabsorbing it. And so something we use, cholestyramine, it's the same thing as styrofoam. Please don't eat styrofoam to lower cholesterol. That's ridiculous. But cholestyramine is something called an anion-exchange resin. For those of you solid phase biochemists, you know that styrofoam is an anion-exchange resin. And it lowers LDL cholesterol as long as we poop the cholestyramine out, as long as we keep our bowels moving. Anything that's a sequestrant, that's going to absorb stuff out of our body, needs to be passed through the stool. Whether we're absorbing cholesterol or potassium, we have to keep the bowels moving for our bile acid sequestrants to work. This may happen with the use of cholestyramine. Anything that we use to absorb something in our bowels and pass through can cause all sorts of abdominal discomfort and irregularities as well. So keep that in mind. But these are very safe, effective ways of lowering cholesterol. One of the problems with the bile acid sequestrants, the main problem with any sequestrant is this right here, taking the other drugs and preventing them from being absorbed. So somebody takes a bile acid sequestrant at the same time they take their digoxin. Well, maybe the digoxin will stick to the bile acid sequestrant and stick to that anion exchange resin and go out the stool rather than being absorbed by the body. So it's very important to inform our patients not to take the bile acid sequestrants at the same time that they take other medications. So we can take the bile acid sequestrant long before we take the other medications or afterwards. Take 1 hour before or 4 hours after the bile acid sequestrant. All right, so take the medications 1 hour before the bile acid sequestrant or 4 hours after the bile acid sequestrant. But otherwise, these are safe to use. There's things called fibric acids. Notice that fibro word, gymfibrozil and fenofibrate. A little bit in tricor. They can lower cholesterol, but their biggest effect is going to be lowering triglycerides. Again, if somebody has high triglyceride levels, and that's secondary hypertriglyceridemia due to diabetes mellitus, these are not going to work as well as somebody who has familial hypertriglyceridemia. And so these are excellent medications to use for familial hypertriglyceridemia. However, in secondary hypertriglyceridemia, like that due to diabetes mellitus, these aren't going to work as well. So that's something to keep in mind, because if you have a diabetic who's manifesting themselves clinically through hypertriglyceridemia, the first thing everybody's going to want to do is put them on these medications. So be on the lookout for that. When I think hypertriglyceridemia, I think it's either familial or I think of diabetes mellitus. And when I look back on things, a lot of diabetics are misdiagnosed as familial when their hypertriglyceridemia is actually due to diabetes mellitus. But that's enough of all that. Fibric acids and the statins, for that matter, cause muscle aches. That's what I want you to know. This right here, muscle aches. Abdominal pain, nausea, diarrhea, gastrointestinal discomfort, common. Not that common, but muscle aches a little bit more common. And they're going to interfere with other drugs that we're going to use to lower cholesterol. So we're either going to use a fibric acid or an HMG-CoA reductase inhibitor. It's really difficult to use both. We're not going to use that with niacin. And then there is an interaction with using that with a blood thinner. Fibric acids, we need to follow their liver function tests on a regular basis and check their CBCs regularly as well. All right, so here are the statins. Lovastatin, atorvastatin, rosuvastatin, Crestor. These are considered the high-intensity statins. There is an enzyme in your body that makes cholesterol, because you need cholesterol in your body. And what we don't need is all the dietary cholesterol that we're getting. And then some people genetically have hypercholesterolemia, and so they don't need to be making cholesterol. And so there is an enzyme in the liver, HMG-CoA reductase, that is required for cholesterol synthesis. So if we inhibit that, then we can decrease cholesterol levels. These drugs are contraindicated in pregnancy. They're category X drugs. I've read all sorts of things. They're like, well, they're not that bad, but they remain completely contraindicated in pregnancy. We certainly don't want to use them when a baby's being developed. It needs the increased cholesterol levels for the baby to properly gestate. And so again, we're going to avoid these in pregnancy. Something that the HMG-CoA reductase inhibitors can do, as well as the fibrates and niacin, is increase liver function or decrease liver function, resulting in increased liver function tests. I think that's right there. Due to this hepatotoxicity, when somebody becomes hepatotoxic, they'll even become jaundiced. And I had a patient, because it's impossible to get a hold of old records, came in and they had severe hypercholesterolemia, and I tried to ask him some questions, and he wasn't really sure of the answers to any of that. And we put him on a HMG-CoA reductase inhibitor, and within 2 weeks he turned yellow. And so he had hepatotoxicity from the HMG-CoA reductase inhibitors. We took him off the we took him off the statins, and he did just fine. All right, so this is usually reversible, as is the myopathy. When we have people who have very high LDL levels, and we're being really aggressive about lowering their LDL levels and improving their atherosclerotic disease or preventing its progression, we see this a lot. And so we have to take this seriously. Somebody comes in, they have muscle aches and weakness. We're going to need to evaluate whether we're using the statins too aggressively. Again, we're going to have to monitor their liver function tests, and we're going to need to continue monitoring their liver function tests. We get this mentality that if you check it the first few times, it should be okay in the future. But what I've seen is that people change. We'll add a different medication to the regimen, and now all of a sudden we have a problem on our hands. So we need to regularly and throughout the course of their use of the statins check their liver function tests. I know I've said the backwards before. I know I've been told the backwards. But after paying attention long enough, we do have to continue monitoring liver function tests in people taking the statins, the HMG-CoA reductase inhibitors, because things can change. Add a different medication, age. So be sure to monitor liver function tests regularly in somebody taking HMG-CoA reductase inhibitors. All right, well, that's all the time we have for this section. When we come back, we're going to talk about congestive heart failure and coronary disease and angina. So until then, aloha.